Nice to see you, ma'am. Yes.
Same with you, ma'am.
Rekha ma'am, you are from Shimoga, correct?
Yeah, yeah. You had told me you had come to Shimoga a long back.
Yeah, yeah, ma'am.
Okay.
And ma'am, I think last month we had a violence against women's.
Yeah. There was
training.
technical issue and I had to do everything.
Yeah. But I was one of the faculty.
Yeah. There was some technical glitch, ma'am.
Yeah,
so
correct.
the faculty online could not,
Connect.
They couldn't connect. Yeah, there was no power, no internet. So I did all the topics.
That's great. That's amazing.
I had to finish, and I couldn't waste the time of the audience also.
Yes. But it's very difficult to pull on all the topics together. No?
I know.
Yes. So are we on time?
Yeah, it was supposed to start at 9:30.
Shriman, are we on time?
Madam, there were 61 registrations and 30 participants are joined, madam. We'll start in.
Yeah, I think we should start.
Yes.
Okay.
Shalini, madam?
Ma'am, good.
Ma'am, shall we start?
Yes, ma'am, sure. Thank you.
Okay.
Shalini, ma'am, have you kept any MOC? Or you are going to do it? Have you kept any master of ceremony or you are going to do it?
Ma'am, we can start the session.
Okay. So Shriman sir, who will announce? Should I come?
Yes, madam. We can start the program.
Okay. So should I share my presentation right now?
Yes, madam.
Okay. I'll do that. Hello everyone. Good morning. I'm Dr. Alka Mukherjee. Today I will be giving a perspective of amendments in the MTP law. We all know the MTP law came into existence way back in 1971. In last 50 years, there was a sea change in the societal norms and needs of women. The facilities for diagnosis of fetal anomalies are advanced. It is an absolute necessary, therefore, or pressing priority to add upon the changes in the existing law to strengthen the access of safe abortion. When you add upon these changes, they are called amendments. These amendments, they include substitution of certain subsections and insertion of certain new clauses under some sections. The MTP law 21 was absolutely ensured the dignity, autonomy, and provided justice for women who need MTP. It has expanded access of women on the basis of therapeutic, eugenic, humanitarian, and social grounds. And therefore, the bill was approved by Lok Sabha on 17th March 2020 and amended by Rajya Sabha on 16th March 21. It's a joint FOXI and WHO initiative, the Respectful Abortion Care. Let us take a closer look at what are the new laws and what are the changes in the law, in the rules. We all know abortions, they constitute the third leading cause of maternal mortality. About 8% of the maternal deaths per year are due to abortions. nearly 2 out of 3 abortions they are performed are seen to be unsafe. Nearly half of the pregnancy-related deaths they are in the women and girls under the age of 24 years. So unsafe abortions in India, they lead to mortality, morbidity, and hamper the total progress of the woman and the girl. When the abortion is considered unsafe, WHO definition of safe abortion is by appropriate method and by trained person. If both the criteria are met, they as abortion are considered safe. It is less safe when only one criteria is met, either the method is not appropriate or the person is not trained. Or when both criteria are not met, it is considered as unsafe. Medical termination of pregnancy amendment law amendments, they are for safe and comprehensive care, which are mandated by the law. What are the modifications or what are the amendments? First amendment is modification in the requirement of provider. Previously, the Act mentioned the requirement of opinion of one provider for MTP up to 12 weeks, and later on, and after for 12 to 20 weeks, there is requirement of opinion of 2 providers for MTP. In the amendments, they said requirement of opinion of one registered medical practitioner for termination of pregnancy up to 20 weeks of gestation, and requirement of opinion of 2 RMPs for termination of pregnancy from 20 to 24 weeks of gestation. What is the outcome? The potential outcome is increase in the number of facilities, especially in the public sector like PSCs, where is only one doctor is there and they can do abortion up to 20 weeks. Then the second modification for the vulnerable group of women. MTP is permissible beyond 20 weeks only when it is immediately necessary to save the life of the pregnant woman. Whereas in 21, the amendments, they say they enhance the upper gestation limit from 20 to 24 weeks, and it is in special or vulnerable categories of the women. Who are the vulnerable categories of the women? They are the violence victims, the victims of rape or the victims of incest and minors among the others, as well as the specially abled women. There's further enhancement of birth defects not comprising who are not compatible with life on medical board consensus. In previous Act, the Act has provision for termination of such pregnancies only up to 20 weeks for birth defects and congenital anomaly. In 21, the amendments, they show upper gestational limit doesn't apply in cases of pregnancies with substantial fetal abnormalities, specially diagnosed by a medical board. So ultimately, the potential outcome is what is the benefit to the society? There is increase in access to safe and legal abortion services. And usually these pregnancies, they seek the abortion care led beyond the legal limits for termination of pregnancy with substantial fetal anomalies. They are diagnosed late, thereby reducing the unsafe abortion and court cases. Hello? Am I audible properly?
Yes, ma'am, you are audible.
Yes, ma'am.
Yes, yes. I'm not getting into who is scribbling on the screen. I'm not getting it. I don't know. There are marks of pain on the screen.
But it's audible, visible, ma'am. You can go ahead, I think. Yeah.
Okay. No issues. Yes. In MTP amendments, modification related to marital status. The previous Act, it mentions the condition of failure of contraception was applicable for only married women or her husband. The amendments in 21, they mentioned condition of failure of contraception to be extended for any woman or her partner. What is the benefit? Is increased access to safe and legal abortion for any woman irrespective of the marriage age, especially with upcoming changes in the legal age of marriage, an important advancement for increasing access to safe abortion. Now, yes, insertion of new clause for strengthening privacy. Previously, the Medical Termination of Pregnancy Act, Pregnancy Regulation 2003, it mentioned that information should not be disclosed except under. Yes.
Sorry to disturb.
Hello?
Ma'am, voice is little bit low. ma'am.
Okay, just hello.
Can-
No, madam, myself is 100% आपके इसमें नहीं आ रहा होगा.
Okay,
My
ma'am.
volume is full. Okay.
Thank you.
Others are listening or not? Hello.
Yes, ma'am, you are audible. Yeah.
Okay, okay. Previously, the insertion of new clause for strengthening the privacy. The Medical Termination of Pregnancy Regulation 2003, it mentioned that information should not be disclosed except under the authority of law. Now, name and other particulars of a woman whose pregnancy has been terminated shall not be revealed except to a person authorized by any law for the time being in force. That is the amendment in 21. What is the benefit? There is increase in privacy and confidentiality of abortion seekers. There is increased demand, but need to safeguard the needs and rights and dignity of the woman and provide respectful, bias-free abortion services, including counseling and contraception. Then, as per the MTP Amendment Act, they prioritize the confidentiality and safety. Names and other particulars of any woman seeking abortion to be kept confidential except to a person authorized in any law for the time being in force, and the ground of failure of contraception has been extended to women and her partner. So that has increased the reach of the woman. Rules under MTP Amendment 21. It defines special or vulnerable category of women eligible for extended gestational period for termination of pregnancy from 20 to 24 weeks. The norms for the registered medical practitioner whose opinion is required for termination of pregnancy at different gestational age. This we are going to cover in next topics. And the powers and functions of the medical boards, particularly which include one person like obstetrician and gynecologist, plus pediatrician and plus a radiologist or sonologist, found from each state and mandated to provide timely evidence-based decisions. Rules under MTP Amendment 21. The special category of women eligible for MTP between 20 to 24 weeks. The first of all, they include the survivors of sexual assault, that is rape and or incest. Then there is pregnancy with termination on humanitarian settings like disaster, humanitarian settings like and disaster and or emergency situations such as declared by the government. Number 3, change of marital status during the ongoing pregnancy, widowhood and divorce. Number 4, pregnancy, women with physical disabilities, major disability as per the criteria under the Disability Act. Number 5, mentally ill women, including mental retardation. Number 6 is minors. And number 7, the fetal malformation that has substantial risk of being incompatible with life. And if the child was born, it would suffer from such physical or mental illnesses. The rules under MTP Act are norms for the RMP. Registered medical practitioner defined in the old Act as MBBS or more with any medical practitioner assisted in 25 cases of MTP, of which at least 5 are done independently in a hospital. Medical practitioner who has completed 6 months of house surgency in obstetrics and gynecology. Medical practitioner who holds a postgraduate degree or diploma in obstetrics and gynecology. Medical practitioner who has experience of at least 1 year in the practice of obstetrics and gynecology. Yes. Hello. Yes, for one RMP opinion was required up to 20. Now it is needed for up to 20 weeks of gestation. 2 registered medical practitioners are their opinion is needed for 20 to 24 weeks of gestation. And medical board opinion is needed for the pregnancies beyond 24 weeks. Under the amended rules 21, an additional category of provider has been added. For termination up to 9 weeks with medical methods, a registered medical practitioner with experience in the practice of OBGYN at any hospital for 3 months or training with performance of 10 cases of MTP by MMA under supervision of a registered medical practitioner in a hospital established or maintained or a training institute approved for this purpose by the government. So one registered medical practitioner opinion is needed up to 20 weeks, then 20 to 24 weeks, 2 registered medical practitioner, and again a medical board opinion is needed after 24 weeks. Then there is the norms for RMP, whose opinion is required for termination of pregnancy at different gestational age. Till 9 weeks we required, experience and training required is experience at any hospital 3 months in the practice of OBGYN or has independently performed 10 cases of MTP by MMA under supervision of a registered medical practitioner in a hospital established or maintained or training institute approved for this purpose by the government. Of course, a practitioner who has assisted an RMP in the performance of 25 cases of MTP, of which 5 has been done independently. It was previously in the law. A practitioner who holds a postgraduate degree or diploma in OBGYN is again there. A practitioner who has completed 6 months or house surgery in obstetrics and gynecology, and a practitioner who has experience at any hospital for a period of not less than 1 year in the practice of OBGYN. This 1st and 5th are added now. Next. Yes. Till 12 weeks experience and training requirement for RMP. Again, a practitioner who has assisted a registered medical practitioner in the performance of 25 cases of MTP, of which 5 has been done independently in a hospital. And again, the postgraduate OBGYN diploma or diploma or degree, and a post-graduation and a practitioner who has completed 6 months house surgency A practitioner who has experience at any hospital for a period of not less than 1 year in the practice of OBGYN, opinion of one registered medical practitioner is required till 12 weeks. Then again, the beyond 12 weeks up to 20 weeks, experience and training required for registered medical practitioner is practitioner who holds a postgraduate degree or diploma, then a practitioner who has completed 6 months of house surgery in OBGYN, and then a practitioner who has experience at any hospital for a period of not less than 1 year in the practice of OBGYN. Opinion of one registered medical practitioner is required. In beyond 20 weeks up till 24 weeks, experience and training requirement of registered medical practitioner. Postgraduate degree or diploma in OBGYN, then a 6 months of house surgery or a 1 year experience in the practice of OBGYN. These are the 3 people. Again, there is opinion of 2 RMPs are required from 20 to 24 weeks of gestation. The beyond 24 weeks, the experience and training requirement for registered medical practitioner, a degree and diploma, a practitioner who has experience at any hospital for a period of not less than 1 year in the practice of OBGYN, and then opinion of the medical board is necessary, required for the termination procedure when advised by the medical board, is carried out with all safety norms along with the appropriate counseling and at an approved place. That is important. Who are all considered in the medical board? The composition of the medical board is a gynecologist, a pediatrician, and a radiologist or a sonologist, whichever is available. What are the powers to the medical board? The number 1, to allow or deny the termination of pregnancy beyond 24 weeks of gestation period, only after due consideration and ensuring that the procedure will be safe for the woman at that gestational age, and whether the fetal malformation has substantial risk of being incompatible with life, or if the child when born would suffer from such physical and mental abnormalities to be seriously handicapped. There is the second power of the medical board is they can co-opt other specialists in the board and ask for any additional investigations if required for deciding on the termination of pregnancy. Please note here, FOXI with ministry guidance and WHO support as part of RAC can operationalize and host medical board information on its website. Then rules under MTP Amendment Act 21. What are the functions of the medical board? To examine the woman and her reports who would approach for MTP, then provide the opinion of medical board in the Form D with regard to the termination of pregnancy or rejection of request for termination within 3 days of receiving the request for medical termination of pregnancy. Then to ensure that the termination procedure when advised by the medical board is carried out with all safety norms along with the appropriate counseling within 5 days of the receipt of the request for medical termination of pregnancy. Please remember the 5 days of receipt of the request. Then remember here, FOXI has an important role to play in ensuring that there is a functional medical board in every state as it is stated in the MTP Amendment 21. Before coming to the post-test and the feedback form, let me tell you, certificate will be awarded to the participants on attending the training and submission of registration, pre-test and post-test and feedback. But let me tell you what are certain things that let us revise the aligned features of the amendments. They are enhancement in upper age limit of from 20 to 24 weeks. There will be a special group category which includes the survivors of rape, incest, and victims of incest and differently abled women and minors. There is no gestational age limit in case of substantial fetal abnormalities diagnosed by medical board, which constitute of a gynecologist, the pediatrician and radiologist or sonologist. The confidentiality of about the names of the woman is ensured under this amendments also. The ground of failure of contraception has been extended to the woman and her partner as well. So the essential protocol of safe and legal abortion are when it is performed by registered medical practitioner and at an approved site under the Act and recorded in Form 2, Form 3. And other requirements of the Act are consent again on Form C, opinion of registered medical practitioner that is on Form 1, monthly reporting on Form 2 are all fulfilled. And the pregnancy should be within the gestational limit approved by the law. The abortion care will be respectful, friends, when you have complete knowledge of the law, when you communicate properly, with appropriate documentation, and not to forget about the follow-ups. That is very necessary. The provider will get the protective cover of this legislation only and only when he or she will fulfill all the mentioned requirements completely. So friends, certificate will be awarded to participants on attending the training and submission of certificate, submission of registration, pre-test. Registration and pre-test have been done already. So you have to give the post-test and fill up the feedback form. Then and then you are going to get the certificates. Thank you so much. In India, abortion is legal. Let us make it safe and respectable. So thank you very much. Over to you. Next speaker, please. Yeah. I'm stopping my sharing. Yeah.
Ma'am, thank you so much, ma'am. That was a very informative session.
Thank you, Shalini. I suppose Dr. Rekha is there now.
Yes, ma'am. Yes, ma'am. Hi, everyone. I'm sharing my screen. The slideshow is not happening. Oh, Shriman, yeah. Are my slides visible now?
Yes, ma'am. Yes.
Oh,
Madam, click on this enable editing button, madam, on the top.
Please make it full screen. Yeah.
Okay.
Top yellow bar, right, madam? Mention as protected view. The file.
Stop chat, new sharer. No. Annotate.
No, madam. Click on this enable editing button, madam, which is at the top, right?
Not there. 1 second. That option is not there, or else you can share the screen.
We are able to see your slides, ma'am.
Okay.
We are able to see the presentation.
Is it full screen now, ma'am?
No, not yet.
Okay, that I'm not able to do.
That's what, madam. There is an the top.
This,
There are bars,
no,
right?
sir.
Like design, slideshow, review, view, tabs, madam. Tabs on the top.
Yeah. No,
And
there's
the
no such thing here.
I feel
There's,
it is lower on the screen. It is at the end. 87% is written over there, no? Then you should click in this on the right side of that. Lower, you will say right lower corner, ma'am.
Okay. No, it's not here also.
Right lower corner. Yeah.
Shriman, you please share the slide for me. I'll just exit this one.
Okay, ma'am.
1 sec.
Stop sharing then. If Shriman is
Yeah.
sharing this thing.
Yes, ma'am. Yes, ma'am. Shriman, you can share now.
Yes, ma'am.
Shriman, if you are not having, I am having ready. You can tell me.
Yes, ma'am. I'm ready. I'm ready.
Okay.
Is it full screen now?
Yes.
Okay. Shall I continue, ma'am? Okay.
Yes.
Friends, so today I'll be speaking about safe abortion and updates in technology. Next slide. So in this session, we'll be discussing about existing guidelines, pre-abortion assessment, medical methods of abortion, and surgical methods of abortion. So there are various WHO global guidelines on safe abortion. We have come through a long journey of making this abortion practice safe and respectable one for our women. Next slide. So the roadmap to WHO safe abortion guidelines is dated back to 2012 when there was safe abortion technical and policy guidance for health systems. Then in 2014, there was a clinical practice handbook for safe abortion released by WHO. In 2015, the health workers' role in providing safe abortion care and post-abortion contraception was stressed upon. 2018, we had guidelines for medical methods of abortion. In 2019, WHO consolidated guidelines on self-care intervention for health. And we adopted these WHO guidelines for application in India. Next slide. So there was landmark amendments on 24th September 2021 in making this whole abortion process a respectable and a comprehensive one, which also includes pre and post-abortion contraception counseling. So the comprehensive care is mandated by law by the MTP Act of 2021. The amendment was done in 2021 and it became an act in 2022. Next slide. Next slide, please. So all the guidelines have got three key areas in the management of performing abortion safely. It starts with pre-abortion care. The next is abortion care methods. The last one is aftercare and follow-up, which includes post-abortion contraception and counseling. So in pre-abortion care, we need to take proper medical history of the patient and do physical examination and lab and other investigations only if necessary and available. And then we decide about the proper abortion care methods, and then post-abortion, we call them for follow-up and also discuss contraceptive options. Next slide. Next slide, Shriman. So now let's discuss about the pre-abortion assessment and counseling. Next slide. The components of pre-abortion assessment for women seeking first trimester abortions. You have to take a detailed history, do a general physical examination and also pelvic examination, laboratory investigations and other investigations if required, then decision-making information on abortion procedures and also counseling, especially about contraception. Next slide. Gestational age determination by LMP or by physical examination. We all know how to assess the gestational age based on the uterine height. So I'll not be going into the details. Now, we also know wherein the uterine size can be larger than actual gestational age, as in uterine malformations, fibroids, multiple gestation, marked uterine retroversion, obesity, and molar pregnancy. So a uterus that is smaller than expected may indicate that the woman is not pregnant at all, or the menstrual dating might be inaccurate, or it could be an ectopic pregnancy or abnormal intrauterine pregnancy like missed abortion. A uterus that is larger than expected is again could be because of either fibroids, uterine malformations, multiple gestation, molar pregnancy, or again because of inaccurate LMP. Next slide. So what about the pre-abortion investigation? Should we do all the routine investigations? No, not required. The routine lab tests are not a prerequisite for abortion services. Tests that may be performed as per individual risk factors on findings of physical examination. Pregnancy test if pregnancy is not confirmed. hemoglobin or hematocrit for suspected anemia, RH testing where RH immunoglobulin is available for RH negative women, HIV testing or counseling, STI screening, usually performed during the pelvic examination. Other lab tests are indicated only if the medical history is suggestive of some medical disease, like kidney or liver function tests are not routinely done until and unless your medical history mandates for the same. Ultrasound is not necessary unless to diagnose pregnancy of uncertain origin, like ectopic or like abnormal pregnancies, like missed abortion, molar pregnancy, etc. So ultrasound is also not mandatory according to the law. Next slide. So what do you do in pre-abortion counseling? Ask the patients about her thoughts about terminating the pregnancy and reason for terminating. So in all cases of MTP, you need to mention the indication for MTP. Inform her that always early abortion is safe and inform her about the importance of a trained provider performing the procedure for safety, the various available methods of abortion, risks and warning signs associated with the abortion method. Without contraception, she can get pregnant as soon as 14 days after an abortion. So she should be made aware of quick return of fertility. And she should be told how early she can resume her normal activities and any other follow-up care if required. Documentation is very important. Please always take informed written consent and decision to accept post-abortion contraceptive. But friends, even if she is not willing for contraception, she will be provided with the abortion services and this should be made known to her. You should not deny or talk disrespectfully to the patient if she doesn't accept contraception. You're not supposed to deny MTP if she is not accepting contraception. Next slide. Clinical management of abortion. Abortion care is divided into two groups, up to 11 weeks, that is less than 12 weeks. What are the global recommendations? It can be managed by either mifepristone and misoprostol combination or by misoprostol alone or by vacuum aspiration. After 12 weeks, the global recommendation says we can use mifepristone and misoprostol combination or misoprostol only or dilatation and evacuation. And it is to be remembered that routine dilatation and sharp curettage, especially even blunt curettage, vigorous blunt curettage is equivalent to a sharp curettage, is not recommended. It is not routinely recommended. You do it only if you suspect incomplete removal or if you suspect retained products of conception, if you're not happy with your suction evacuation. Otherwise, it's not routinely recommended. This can prevent Asherman syndrome and sepsis. The Government of India recommendation is medical method of abortion should be used only until 9 weeks. So up to 7 weeks, we all know that the result is almost 99%. So up to 7 weeks, MMA works very well. Give mifepristone 200 mg orally. Ask the patient to come back after 24 to 48 hours. Then misoprostol is given 800 micrograms sublingual or buccal. The PV per vaginal administration can also be done. What you do between 7 to 9 weeks, you can still give medical method of abortion, but tell the patient that there are chances of failure and she might require repeat dose of misoprostol or sometimes even surgical evacuation. Again, it's the same protocol, mifepristone 200 mg orally, followed by misoprostol 800 micrograms sublingual or buccal or PV 24 to 48 hours later. Next slide. Clinical management of abortion. So the various methods of first trimester abortion, as I told you, it could be medical method of abortion, which is very, very effective up till 7 weeks, 7 to 9 weeks, almost effective. Then 9 to 12 weeks, it's better to go for MVA, manual vacuum aspiration or electric vacuum aspiration. Next slide. So what is this mifepristone or misoprostol combination? Mifepristone, as we all know, is an antiprogestin, inhibits the action of progesterone. It interferes with continuation of pregnancy. The initial oral dose of mifepristone is followed by misoprostol, which is a prostaglandin-E1 analog. Misoprostol causes cervical softening, uterine contractions, expulsion of products of conception. Next slide. So what are the advantages of tablet misoprostol? The slide is not showing that. The same thing, whatever I told you earlier, it will soften the cervix, prepare the cervix for the procedure. It will initiate uterine contractions, and most of the patients will even expel with misoprostol alone. So what are the various protocols? Day 1 mifepristone, 200 mg mifepristone orally. And if the patient is Rh negative and the partner is Rh positive, then anti-D 50 microgram is given. On day 3, patient is asked to come back 48 hours later. This is a typing error. This is misoprostol. Up to 7 weeks, you can give 400 microgram misoprostol, sublingual or buccal or vaginal or oral. Or from 7 to 9 weeks, you can give 800 micrograms sublingual or buccal or vaginal. In addition, you can give symptomatic treatment for the side effects of the misoprostol, like pain. For pain, you can give ibuprofen 400 mg. Antiemetic is rarely required, but if at all it's required, you can give metoclopramide, or if it's severe, you can give Ondem, but hardly any medication is required for vomiting. It is self-resolving. And you please offer contraception at every visit. Within day 15, again, the patient is asked to come back for follow-up after 2 weeks. Confirm and ensure completion of the procedure, and again offer contraception if she has not accepted contraception previously. Next slide. So what are the characteristics of different routes of misoprostol administration for first trimester abortions? Orally, here the misoprostol tablets are swallowed. Oral tablets can be given up to 7 weeks for first trimester abortions. Side effects include diarrhea and nausea, fever and chills. So side effects are always more with oral administration. Buccal administration, here pills are placed between the gums and the cheek, and the patient is asked to swallow the tablets after 30 minutes. There'll be more fever and chills than with the vaginal route. Sublingual, pills are placed under the tongue and swallowed after 30 minutes. Here, the onset of action is the fastest and the plasma concentration levels will be highest. But again, the side effects will also be highest. There will be increased fever, chills, diarrhea, and vomiting compared to the vaginal route. Then coming to the vaginal route, pills are placed in the vaginal fornices in the deepest portions of the vagina, and the woman is instructed to lie down for 30 minutes. Pill fragments may be visible when you do a PV examination 4 hours later, but it has got the lowest rate of side effects. So in order to make the pills dissolve quickly, you can wet the tablets with distilled water. Next slide. Next slide, Shriman. So this is a diagrammatic representation of buccal administration. The tablets are kept between the gums and the cheek in the sublingual route just below the tongue. Next slide. So the same thing has been discussed here. WHO drug regimens, dose schedule for medical abortion are the same. You have to tell the patient that vaginal bleeding for 2 weeks is normal after medical abortion. But in case she feels dizzy, feels weak, or too much of bleeding, like more than what she used to have during her period, then she should come back anytime, or else she should see you only after 2 weeks. But such minimal amount of bleeding spotting can last even up to 45 days in rare cases. Next slide. Provision of MMS services. Where are these made available? Services should be available at the primary care level with referral systems in place for all required higher level care. Additional services may need to be provided. There's a lot of disturbance. Somebody has not muted. Okay, thank you. So services should be made available at the primary care level with referral systems in place for all required higher level care. Additional services may need to be provided to individuals seeking medical abortion, which include counseling and testing for sexually transmitted infections, especially if you suspect high sexual risk behavior, high risk behavior in your patients. Abuse support services. You have to also address violence against women, psychological or social services, or other specialist health or medical services. Provide iron tablets for anemia if required. Provide any necessary pain medications, and provide emotional support if needed. Next slide. So the follow-up care will include routine follow-up will not be necessary following an uncomplicated medical abortion using mifepristone and misoprostol, especially for MTPs less than 7 weeks, since we know it's very, very effective and almost 99% effective. But a follow-up visit 7 to 14 days after the procedure may be offered to provide other services. As I discussed, the other services meaning contraceptive counseling and services, emotional support, or to address any other medical concerns, along with confirming your completion of the procedure. A routine follow-up visit is recommended only in case of medical abortion using misoprostol alone to assess the success of the abortion, especially when you are doing medical method of abortion between 7 to 9 weeks, you can call them back. Or when you have not used mifepristone and used only misoprostol, you can call them back. So what do you do in the follow-up care? Assess the woman's recovery and ask for any signs or symptoms of ongoing pregnancy. Sometimes it could be ongoing pregnancy and you would have thought she has aborted. So ask, confirm the completion of the procedure for asking for signs and symptoms of the ongoing pregnancy. Review any available medical records and referral documents. Ask about any symptoms experienced since the procedure. Perform a focused physical examination for any complaints. Assess women's fertility goals and need for contraceptive services if not provided earlier. Next slide. So to summarize medical method of abortion, next slide. So what to do? On day 1, you'll be doing physical and pelvic examination, confirm eligibility, that is up to 7 weeks. As I told, you can assure the patient that it will be complete. Tablet Mifi 200 mg orally, offer anti-D 50 microgram to RH negative women. Tell the woman to return for misoprostol administration after 48 hours. Contact address and phone number of the facility or center where she can go in case of any emergency. Record her experience of any side effect on the MMA card. 3% of women may expel completely with mifepristone alone, but misoprostol schedule should still be completed. Next slide. So what do you do on second visit? Day 3, give misoprostol 400 micrograms sublingual or buccal or vaginal or oral if she is less than 7 weeks, or the dose becomes 800 microgram between 7 to 9 weeks. Less than 7 weeks, they say 400 is good enough. Observe for 4 hours. For pain, you can give 400 mg ibuprofen and you can give contraceptive options. You can advise about condoms and start off OCPs and injectable DMPA in your second visit itself. Tell the woman that the mean period of bleeding is 8 to 13 days. The possible side effects are nausea, vomiting, diarrhea, headache, fever, and dizziness. Report in case of excessive bleeding, pain, abdomen, and fever, and report if there is no bleeding 24 hours after misoprostol. 75% of women abort within 6 hours after misoprostol administration. So third visit, day 15, what do you do? Pelvic examination to ensure the completion of abortion. Advise contraceptive options, hormonal methods, condoms, IUCDs, and sterilization. After 1 menstrual cycle, tell the woman about immediate return to fertility as early as 10 days to 4 weeks. Report back if there are no periods within 6 weeks of completion of the abortion process. Ultrasound only if examination does not confirm the completion of procedure. So please don't tax the patient by doing a routine ultrasound on her third visit. Next slide. So what are the side effects and complications? Next slide. We all know pain. So please be very respectful and non-judgmental while talking to the patient. Don't say that she has to tolerate pain because she herself has come to seek MTP. No, don't talk disrespectfully to the patient. Don't be judgmental. Don't assess her pain. Okay. Don't neglect her pain. Don't tell that this is a mild pain and that she has to tolerate. No. Give her verbal support, give adequate counseling, support the person, give ibuprofen 400 mg. Persistent pain with failure to respond to analgesics for several hours warrants evaluation for other causes such as ectopic pregnancy, infection, or incomplete abortion. So always respect the symptoms of the patient. Nausea and vomiting is usually self-limiting, as I told you. Just reassure her. If required, give antiemetics. Diarrhea is usually self-limiting. Reassure or give symptomatic treatment. Infection, confirm by physical examination and start antibiotics. Next slide. Action for failure or incomplete result of MMA. So what do you do when your medical method of abortion fails? Failure of MMA, you can either repeat a medical method of abortion or offer vacuum aspiration. If there is incomplete result of MMA, that is, if there is incomplete abortion or you see there is retained products of conception, what do? You observe unless there is heavy bleeding. If the bleeding has resolved and the uterus is of normal size, then you assume that the abortion is complete. But if the heavy bleeding continues, then what do? We usually do vacuum aspiration. If there is retained products, you either repeat misoprostol or offer surgical method of evacuation. Especially if the heavy bleeding continues, you go on to perform vacuum aspiration. Next slide. So excessive bleeding PV, how do you manage? Woman presents with excessive bleeding PV. What do you mean by excessive bleeding PV? She's soaking 2 pads in 1 hour, bleeding more than her menstrual cycle. If the bleeding decreases over time, then just keep a watch on her vitals and bleeding PV, and she can go home after a period of observation. If the bleeding doesn't decrease over time, watch for her vitals, do PV examination. If there are any retained products in the cervical canal, please do digital evacuation. If following digital evacuation, the woman becomes stable and the bleeding reduces, again observe and monitor her vitals and watch for bleeding PV for 1 more hour. If the bleeding continues in spite of your digital evacuation, please do an ultrasound. Ultrasound might sometimes show minimal decidual bits. Minimal decidual bits meaning less than 1.5 centimeters. You need not do anything, just wait and watch. Okay, if the products of conceptions are there, is significant, more than 1.5 centimeter or the decidual bits, but the woman is stable, you can go for medical management. That is misoprostol 600 microgram oral or 400 microgram sublingual. If the woman is unstable, then you don't have time for medical method. Just go ahead with vacuum aspiration. And sometimes the ultrasound might show that the pregnancy has continued. In such a case, go ahead and do vacuum aspiration. Next slide. Recording and reporting for MMA. Yes, even for medical method of abortion, even if you do it on OPD basis for less than 7 weeks, please record everything. Everything should be documented. Since MMA comes under the purview of the MTP Act, the documentation is similar to that required for the vacuum aspiration procedure. It is mandatory to fill following forms. Form C for consent. This is the consent form. Form 1 is RMP opinion regarding indication and the eligibility of the patient for the method. Form 2 is monthly reporting form, which is to be sent to the district authorities. Form 3, admission register for case records. Next slide. So what are the surgical methods of first trimester abortion? This is manual vacuum aspiration and electric vacuum aspiration. Next slide. The surgical abortion methods in first trimester are vacuum aspiration and electric vacuum, MVA and EVA. Together they are called vacuum aspiration. This is the recommended technique of surgical abortion for pregnancies up to 12 weeks. So 9 to 12 weeks, we adopt vacuum aspiration. WHO recommends manual vacuum aspiration as the safest method when compared to electric vacuum aspiration. The procedure should not be routinely completed by sharp curettage in order to prevent sepsis, Asherman's, and so that we don't hamper her future fertility prospects. Next slide. So what are the vacuum aspiration methods? Procedure of abortion performed the same regardless of the type of vacuum used. In MVA, as we all know, this is a handheld aspirator used to generate vacuum. Aspirator is attached to the cannula of 4 to 12 mm in diameter. Cannula can be used in multiple settings, including those without electricity. So here there's no need of electricity. It has got easy grip cannula size corresponds with the weeks of gestation. So for 8 weeks gestation, use 8 mm cannula. For 10 weeks gestation, use 10 mm cannula. For 12 weeks gestation, you can use 12 mm cannula accordingly. Next slide. So this is the picture of the MVA. All of you would have seen. This is the electric vacuum aspirator. There's an electric pump which we use for all the surgeries, cesarean sections, hysterectomy. The same cannulae are connected to this electric pump to generate vacuum. It can accommodate the cannula of manual vacuum aspiration with correct size tubing. So proper tubing is required in order to connect to the size of the suction cannula. Next slide. But before doing surgical abortion, in order to prevent damage to the internal loss and to prevent cervical incompetence in future pregnancies, it's always better to prime the cervix. It may be considered for women with a pregnancy of any gestational age in order to prepare the cervix and make it soft and easy to dilate. So easy dilatation, no damage to the internal loss. Forceful dilatation or rapid dilatation of the cervix can damage her internal loss and lead to cervical incompetence in future. So what are the recommended methods of cervical ripening before surgical abortion first trimester? It is either oral mifepristone 200 mg, which is given 24 to 48 hours in advance, like in MMA, or misoprostol 400 microgram administered sublingually 2 to 3 hours prior to the procedure, or misoprostol 400 microgram administered vaginally 3 hours prior to the procedure. I think all of us are following this one, misoprostol 400 microgram vaginally, right, since ages. Then we have laminaria placed intracervically 6 to 24 hours prior to the procedure. Next slide. So what is the pain management plan for vacuum aspiration procedure? It's an important component of quality abortion care. The pain should be taken care of. It reduces pain and anxiety and makes women comfortable. What are the two components of pain management? They're non-pharmacological and pharmacological. Next slide. Non-pharmacological pain management includes providing psychological support, explain each step to the woman in advance so that she's ready, performing, so even the patients who go into labor, if educated and counseled about the various stages of labor during her antenatal period, she'll cooperate well during labor. So the same here. So please explain each step to the woman in advance so her pain management, her pain tolerance is better. Performing the procedure gently and smoothly, encouraging the woman to relax and breathe deeply. Next slide. Pharmacological pain management plan. So for anxiety, you can give anxiolytic, diazepam, 10 mg orally 1 hour prior to the procedure, or 2 to 5 mg IV 20 minutes prior to the procedure. The effect will last for 6 hours. And the patient might feel dizzy and disoriented, or if the patient is very anxious, you can resort to general anesthesia, short GA. Cervical dilatation, pain. The pain due to cervical dilatation can be taken care of by paracervical block using 10 ml 1% lignocaine or analgesic, ibuprofen 400 mg given 1 hour prior to the procedure. So paracervical block will last for 1 hour, while brufen effect will last for 6 hours. The patient will have gastritis because of NSAID. Lignocaine can cause little dizziness and sometimes seizures. So better to do it, in the presence of an anesthesiologist. Uterine cramping, analgesic ibuprofen, 400 mg 1 hour prior to the procedure. The effect will last for 6 hours. The common side effect of NSAID, as you know, it will cause gastritis. Next slide. What are the various methods of manual vacuum aspiration? I think all of us should be able to use manual vacuum aspiration. Such a simple but wonderful instrument. See, this has got a plunger under syringe. Initially, you need to close both the wall buttons and pull the plunger. This will create a vacuum. Now, prepare the woman. Ensure pain control medication. Ensure that the pain control medication is given at the appropriate time. Ask the woman to empty her bladder. Step 3, you have to perform cervical antiseptic preparation by using betadine. Then administer paracervical block in order to mitigate the pain of cervical dilatation. We all know how to do paracervical block. Then dilate the cervix with serial Hegar dilators. Then you insert the cannula. Next slide. After inserting the cannula, as soon as you feel the resistance, withdraw the cannula. Withdraw the cannula 1 to 2 centimeters away from the fundus inside the uterine cavity. Then what do? Fix your syringe to the suction cannula. Rotate the cannula from 10 to 2 o'clock position with smooth, gentle motion. And finally, you release the vacuum buttons on the aspirator. So all the contents of the uterine cavity will get sucked into the syringe. What are the signs that the uterus is empty? Red or pink foam without the tissue passing through the cannula, gritty sensation of the surface, cervix gripping over the cannula, uterus contracting around the cannula, and increased uterine cramping. Inspect the tissue and proceed with contraceptive methods if the patient has accepted your advice. You can go ahead with IUCD insertion or sterilization. Instrument processing, instruments should be soaked in chlorine solution. It will assist disinfection and help remove the tissue and body fluids. Next slide. So what is the post-procedure care? Monitor her for any complications and provide management as needed. She may leave the facility when she is stable and meets the criteria for discharge. Ensure that the woman has all necessary information and medications prior to leaving the facility. Document all the outcomes of the treatment, including any adverse events, in the facility register and client's record card. Next slide. So what is aftercare? Management of abortion complications like incomplete abortion, infection, bleeding, and ongoing pregnancy. Provision of contraceptive information and offer contraceptive counseling and methods. See, MTP should not become a way of contraception. That is happening because patients are coming repeatedly for, they're coming for repeated MTPs because they're not aware of various contraceptive methods. We are lagging behind in contraceptive counseling. So this is a very important component of comprehensive abortion care. Assessment of any other sexual and reproductive health needs that may require additional care. There is no need of a routine follow-up unless misoprostol alone regimen is used. This is the new recommendation. Next slide. In summary, India has made historic progress in improving access to safe abortion. Not much has changed in the technological update in the last decade. As providers, it is up to us to ensure safety and quality, especially in context of the amended law. Along with safety, we also need to focus on respectful abortion services. Don't comment even if she is gravida 7 or gravida 6. Don't comment badly even if she is not accepting contraception. There are a lot of social factors which have driven the lady to get pregnant, and it has taken a lot of courage on her part to come to you to seek MTP. Every client, public or private, should have an opportunity. You should make use of the opportunity to inform, educate, and equip with proper information on contraception counseling. Next slide. So please don't forget to take the post-test and feedback. Next slide. There were a few more slides on technology, right?
No, madam.
Okay, fine. Thank you so much.
Welcome, ma'am.
Sriman, should I start?
Yes, sir.
Yeah. First, you have to make me co-host, I think. Then only I can share the slides. Okay. Good morning and namaskara to all of you. And first of all, at the outset, I would like to thanks to the Foxy leadership who have take the initiative and pain and give the teaching and training of this very, very important topic. Second, I would like to thanks to the Chittoor Society, especially the Secretary, Madam Salini Madam, for taking all the pain and to organize this wonderful training. And it's really, really, I was shocked because it is in the mid of the week and in the morning hour, there is so much attendees. So thank you so much for coming and getting us the time. Now I would like to share my slides. My dear friends, we Indian West always think that we Indians give very less importance to the rights of our women. But I am very proud to say, and I really feel very proud because in 1960s, India is among the first country of the world who ever think of giving the safe abortion law to the women. So I must congratulate to that time, that leadership of the government of India. And I also, because at that time when the Santi Lal Saha commission was made, the Foxy was, invited as a representative for making this law. So again, I am very proud of my Foxy leadership and I am proud to be a Foxian. So the topic allotted to me is the module 3, that is the safe abortion value, evidence, right, oblique respect of the saver. My dear friends, myself, Dr. Apurv Kumar Datta, I am the National Coordinator of the Sexual Medicine Committee, Foxy, from Dhanbad Society. Now, this module A, that what actually the meaning of the respectful abortion care about according to WHO standard. Now, the second aim is to highlight how the norms and stigma affect these services. And third, to provide WHO saver resources for the respectful abortion care. Now, why from last 2 years we are talking about the respectful abortion, respectful abortion, respectful abortion? The reason is the momentum has been created by the law has been changed, as already discussed beautifully by Alka ma'am and Rekha ma'am. And second, the Foxy targeted the largest provider based for the abortion care take this initiative that they should give teaching and learning about the basic respectful abortion care. Third, the online training is possible due to COVID. My dear friends, I always used to say that COVID gave a lot of pain to us, but this is one of the positive aspects of the COVID, that online training and online, these webinars are possible due to COVID, and which give us a lot of benefits. Now, the MMA uptake increase, it ensure the early, safe, and ensure no PCPNDT conflation. So, my dear friend, patient safety, respect, and quality matters more than ever, and we all have a role to play. Now, when we are talking about the respectful abortion, what is all actually the respectful abortion is? Now, this is adapted from the respectful maternity care, which is recommended by WHO. The respectful abortion care referred to that maintain safety, dignity, confidentiality, ensure freedom from harm and mistreatment, and enable informed choice and continuous support during and after all type of abortion services. In a simpler word, you, like as a provider, treated with dignity, empathy, and compassion, regardless of your race, ethnicity, gender, socioeconomic status, or reproductive history, like number of pregnancies, miscarriages, and abortion. So, in a simple way, When a patient is coming to with you for an abortion, we should respect their care, respect their, their thinking of being to be abortion, and when they are want to get abort, irrespective of socioeconomic condition, irrespective of genetics, irrespective of the ethnicity. If you ever feel that something is not right, speak up. As a health profession, it is our duty to listen and support. Communication is the key. Now, what is the norm and stigma? The norms, stigma are the category of disrespect and abuse. It might be in the form of physical abuse, like slapping, or the verbal abuse, or the sexual abuse, stigma and discrimination in the name of socioeconomic condition, in name of ethnicity, in name of caste or religion. Failure to meet the professional standard of the care. Proper rapport between women and poor rapport between the women and the provider. The health system condition and construction are not adequate. But my dear friend, there is a right of every woman that she should be freedom from harm and ill treatment, right to information, the protection under law like MPP law and POXCO law, informed consent and refusal, respect for the choice and preference, dignity and quality of the care, right to timely health care and to the highest attainable level of the health, liberty, autonomy, self-determination, and freedom from coercions, irrespective of which ethnicity or which background the lady is coming. Now, what is the different domain of the respectful abortion care? There are 12 domains. The domains are being free from harm and mistreatment, maintaining the privacy and confidentiality, preserving women's dignity, respecting women's choice, engaging with the effective communication like soft skill, providing information and seeking informed consent, ensuring continuous access to the support, enhancing quality of the physical environment and resources, provide equitable abortion care, availability of contempt and motivated provider, provision of contraception advice and commodity security, continuity of the care and the counseling. Now, these are the various domains. Now, it's the time to is strengthening our implication of this respectful abortion care. As already very beautifully explained by Alka ma'am, the one provider, what is the time has changed for the provider opinion. Every patient is an opportunity for respect, and as a provider, onus is on us to educate and to also reduce sex selection abortion. So as already stated, one RMP can do MTP up to 20 weeks. Up to 20, from 20 to 24 weeks, 2 RMP is required. And even beyond 20 weeks, irrespective of gestation, medical board is required to do an termination of the pregnancy. Now, second is the expands eligibility, especially young women, survivor, unmarried. Everyone need unbiased care, and we need to overcome our own bias. So all women up to 20 weeks of gestation should be given this abortion care. The special category, like in case of rape or a young less than 18 year of age want for the MTP, yes, we have to inform the people, police according to POSCO Act, but we should provide this abortion care up to 20 to 24 weeks. And if there is a birth defect, there is a no gestation limit, but the board is needed. Now, next is the prioritization, confidentiality, and safety. Respect the biggest respect. The provider, we need to be mindful of the socio-cultural aspect. Name and other particulates of any women seeking the abortion is a confidential except to a person who is authorized in any law for the time being enforced. The ground of failure of the contraceptive has been extended to women and her partner. So my dear friends, give the abortion care with the respect, quality, and dignity at all type of abortion. Now, WHO training of the shaver. We have a very two beautiful videos at the end of this lecture. We will share. Now, so my dear friends, in 1970, from unsafe abortion to 2000, it's a safe abortion, and now in 2020s, it's the respectful abortion. I have a few questions for you, which we usually encounter in our OPD. According to WHO, restricting access reduces the number of unsafe abortion. What's your opinion? My dear friends, it is actually the false. Because if when you are restricting the access to the number of the abortion, the unsafe abortion is actually increasing. So as has already beautifully explained by Rekha ma'am, when we are there is a two criteria, that is by appropriate method and by the trained person. If the both criteria are met, we call it as a safe abortion. If only one criteria is met, we call it as a less safe abortion. If no criteria is met, we call it as an unsafe abortion. Now, the second, we already, and we usually find this type of patients in our OPDs, the 30-year-old women, recently widowed, wanted to get an abortion at 22 weeks. As a provider, it is your responsibility to tell her to continue the pregnancy. What's your opinion? My dear friends, no. What I have already stated, we should always respect the choice of the patient. But yes, as a care provider, we should discuss every aspect of being the complications or whatever be, but the final onus is lies on the patient who are seeking the abortion care, and we should not impose our thoughts on their mind. As I already stated, up to 20 weeks, it's 2 RMP, 1 RMP, 20 to 24 weeks, 2 RMP, and at any gestation age, medical board is required. So, my dear friends, in India, abortion is legal. Let us make it safe and respectful. Samarth Bharat, Sampurn Bharat, and make the abortion is actually the respectful abortion. So thank you so much from my parts. Before I end up with the slides, I would like to share you the videos, the beautiful videos. Shriman, can you please do the needful?
Yes, sir, I will.
Till Shriman has shared, there's a one question that how this medical board is formed, and this medical board is basically comprises of a radiologist, gynecologist, and pediatrician. Where the radiologist is and it is assigned by your local administration. Like in our places, it is the civil surgeon office. When we give application to them, there is a medical board is formed, and which I said is comprised in minimum of these three people. And if they are saying yes, this birth defect is incompatible to life, or this birth defect is actually will cause a lot of problem if the baby is delivered, and if there is saying okay, then we can go with the abortion care. So thank you so much. Yes, Shriman, please go ahead.
Social norms are the unwritten rules of behavior that are considered acceptable in a group or society. Norms can change according to the environment, situation, and/or culture in which they are found. People's behavior may also change accordingly. What are some examples of social norms? In times of COVID-19, there are new social norms that are considered COVID-19 appropriate behaviors like wearing a mask, maintaining social distance, and to wash or sanitize our hands regularly. An example of a social norm that we must follow at all times is to not use profanity in conversation, especially formal or official conversations or when talking to patients, clients. Now let's look at some examples of social norms around gender. Girls wear pink, boys wear blue. This is a gender stereotype. Girls and boys can choose to wear whatever color they like. Color has no gender. Men should be working, strong, and not show emotion. Women should be caring and nurturing and stay at home. Men should work and make money. Women should take care of housework and children. There is no need for women to own or inherit property. Now let's look at a few examples of norms around sexual and reproductive health. Just as norms around gender are smaller aspects of some broader social norms, norms around sexual and reproductive health also trickle down from certain norms around gender. According to the WHO, good sexual and reproductive health implies that people are able to have a satisfying and safe sex life and that they have the capability to reproduce and the freedom to decide if, when, and how often to do so. A woman should be married before getting pregnant and having children. Adolescent sexuality and premarital sex are unacceptable and immoral. Women are responsible for contraception. Now we see what is stigma. Stigma can be understood as a shared understanding that a person, a quality, or circumstance is somehow morally unacceptable. What are examples of sexual and reproductive health stigma? A shared understanding that sex before marriage is morally wrong and or socially unacceptable. A girl who uses a contraceptive method is promiscuous and will have problems when she decides to get pregnant. A married woman is more deserving of contraceptives than an unmarried woman. A girl who has had an abortion is committing a sin and brings shame to her community. Having an abortion has long-term health effects and the woman's health will never recover to her pre-abortion state. Women who have had an abortion once would become habitual and avoid using contraception. It is important to understand that norms and stigma are different from laws and policies. For example, an unmarried girl seeking abortion is considered immoral due to stigma, whereas, as per law, sex selective abortion is illegal in India. In this exercise, we explore how social norms and stigma influence access of reproductive health and rights, how people experience SRH stigma, the impact social norms and stigma have on our actions personally and professionally, and the impact they have on the actions of others, personally and professionally. How to talk about abortion, a guide to right-based messaging. Abort a child is medically inaccurate as the fetus is not yet a child. Terminate a pregnancy is commonly used. However, some people prefer to avoid this as terminate may have negative connotations for some people. For example, terminator or assassinate. In some contexts, the word abortion can be perceived as negative. In these situations, it may be helpful to avoid the word completely and use termination of pregnancy instead. It is important to be legally accurate, and in India, abortion is legally permitted to the full extent of the law. However, in many parts of the country, the barriers to access may be so great that abortion is considered by many to be illegal due to conflations with other laws. Make sure that you share accurate information about the legal situation and make the circumstances under which abortions are legal clear. See the WHO Global Abortion Policies database for information on the legal status of abortion across the world. Let us look at some stigmatizing words and how to avoid them. Abortionist is a term used by those opposed to abortion. Healthcare provider is usually a more accurate term to use than abortion provider, as most of those providing abortion care also provide other health services. In India, they are also called RMPs or Registered Medical Practitioners. The preferred terms are medically accurate as the embryo or fetus is not a baby. When referring to the tissue examined following a surgical abortion, an appropriate term is products of conception. However, this term is only useful for materials focused on medical details of abortion, as it is not commonly used or understood outside of medical or scientific contexts. Conscientious or moral objector implies that those who do provide abortions are not conscientious individuals, which is incorrect. Refusal to services must be well founded. For example, sex selective abortion in India is illegal. This tends to suggest an act of wrongdoing, placing unwarranted blame on the woman and frames parenthood as punishment. The right to abortion should never be linked to how or why a woman becomes pregnant. Abortion is a woman's right and choice. Consider the classification of pregnancies into the categories unintended, unplanned, unwanted, or mistimed. The classification relies on a framework that assumes that pregnancy is, should be, or even can be a conscious decision. The complexity and possible ambivalence of pregnancy intention, as well as the dynamic nature of childbearing decisions before, during, and even after pregnancy, are not accommodated in these classifications. The suffix "side" denotes killing, which is not appropriate when describing abortion. When referring to sex-selective abortion, it is more accurate to describe the practice in terms of choosing to end the pregnancy based on the predicted sex of the fetus. Make it clear that abortion is about making an informed decision, and avoid the implication that ending a pregnancy is done without careful thought or consideration. The term keep implies a positive outcome, which may not accurately reflect the situation. In addition, it is medically inaccurate to describe the pregnancy as a baby or child. It is more accurate to describe the situation as a pregnant woman choosing to continue with the pregnancy. Late term could refer to any time in the second or third trimester. Instead, if necessary, use terms that indicate the specific trimester or gestation. Use of late may also imply that a woman is late and thus irresponsible in seeking an abortion. For example, there is no gestation limit for birth defects and associated abortions in India as per the recent MTP amendment of 2021. Use of mother, father, parent during a pregnancy is value-laden and assigns roles that the man or woman may not accept. It also implies that the fetus is a child, which is not accurate. Also, under the MTP Amendment 2021, in India, any woman and her partner, married or unmarried, can seek abortion. Abortion is not contraception. Contraception is to prevent a pregnancy, whereas abortion is to terminate a pregnancy. People often seek abortion due to the occurrence of an unintended pregnancy or for health reasons, and there will always be a need for safe and legal abortion. All reproductive choices and care should be available and supported. People should be supported to prevent unintended pregnancies with access to contraception and accurate information. Pro-life implies that those who support legal abortion access are anti-life, which is inaccurate. Instead, use alternative terms to make it clear that you are referring to individuals opposed to anyone having an abortion. Where possible, our language should reflect the fact that we are service providers with a focus on providing rights-based quality healthcare and support. In order to dispel myths about organizations that provide abortion care, it might be useful to avoid business-related language. Multiple and repeat can have negative connotations, such as repeat offenders. Multiple and repeat also imply that each abortion experience for a woman is the same, whereas each abortion is surrounded by a unique set of circumstances. If safe, what is wrong with having multiple abortions? Because abortions happen under a wide range of cultural, legal, and medical circumstances, it is important to be careful about the terms that you use to avoid mixing up terms and creating confusion. Here are a few phrases to be aware of. Illegal abortions are those that do not comply with a country's legal framework but may be safe if performed by a trained provider or when a person has access to high quality medication, information, and support to safely undergo a medical abortion in a safe and licensed place. Remember, abortion is considered safe as per WHO guidelines when the 3 P's provider, place, and process are safe, trained, and certified. Unsafe abortions are performed by providers who are not registered or trained, or in situations where people are unable to safely undergo a medical abortion due to lack of access to high quality medication, information, or support. It is possible to have an unsafe legal abortion. Unwanted pregnancy is a pregnancy that a person decides they do not desire. Unplanned or unintended pregnancies refer to pregnancies that occur when a person is not trying to get pregnant. An unplanned or unintended pregnancy may be either a wanted or unwanted pregnancy. In India, abortion is legal, but sex selective abortion is illegal. Provider and place need to be safe, trained, and certified.
No woman should die due to an unsafe abortion, and when abortion is provided, it should be given in a legal and evidence-based manner with quality, safety, dignity, and respect. WHO has a toolkit on safe abortion values, evidence, and rights, or WHO Seva, which is a module-based training for doctors, nurses, health providers, program managers, and really anyone to assess our values, address our biases, and learn together to transform our attitudes towards respectful abortion care for anyone who needs it. During the COVID-19 pandemic, we adapted and converted the WHO Seva toolkit into an innovative, gamified, hybrid version that you can do either in person, online, or as a combination with an expert trainer, or simply by playing one of the standalone games to learn from the comfort of your home. Seva has 4 modules: Engage, Inform, Explore, and Equip. In the Engage module, participants review recent media stories from the country about gender, unintended pregnancy, the realities of safe and unsafe abortion, and juxtapose these with the global standard definitions. In the Inform module, participants share and discuss background information on SRHR, on safety of legal abortion, contraceptive prevalence, abortion incidence and safety, abortion law and safety, and achieving reproductive rights in the global and regional or local context. In the Explore module, participants will play various games and watch videos relating to gender, safe abortion, preventing unwanted pregnancy, explore social norms and values, and consider how these may be rooted in stigmatizing attitudes or contribute to stigma from a personal perspective. The Equip module is to promote knowledge of, interest in, and further use of WHO guidelines and tools, with a focus on guidelines and tools relevant to contraception, abortion, and post-abortion care, towards the many steps needed for achieving the Sustainable Development Goals, also known as SDGs, building resilient health systems for universal health coverage, or UHC, leaving no one behind. We must remember quality and dignity of care matter as much as saving lives. SAVOR is our small step towards SDGs, starting with ensuring safe abortion is provided with values, evidence, and rights or respect.
Sharmila madam, you can take your topic, ma'am.
Okay, I just start. After going through the different modules for abortion service modules, and this is on pre and post abortion family planning counseling, and where you can leverage technology for referrals and online consultations, and that for the COVID pandemic has helped us to go on to offer family planning services through the online platform. And how do you counsel a patient when she has come for an abortion services? Every center needs to have a place where you can offer a structured interaction, and the person will have to voluntarily receive emotional support and guidance specifically from a trained person, and that should be in an environment that is conducive to open sharing of thoughts, feelings, and perceptions. This forms a part of respectful abortion care. You sit and talk with her, offer the support needed before she comes to a decision of whether to go ahead with the abortion or not. And you can utilize this opportunity to talk about contraceptive services also, because she'll be quite receptive when she's asking for an abortion. And the counseling should always form a part, an integral part of all comprehensive abortion services in every center, maybe it's small or big. And it is as important as the procedure itself. The lady will need to have help in decision making, and whenever possible and needed, the spouse should also be counseled so that it's a decision of the family. To decide about the termination of a pregnancy, it will help her to choose the method of termination, and you need to ensure that the complete information is given regarding the procedure as well as the problems that can happen and what are the remedies for that. And it will also help the lady to adopt a contraceptive method even when she's asking for an abortion. And when you're offering the abortion services, ensure total privacy and confidentiality. Be non-judgmental and be very sensitive to the needs of the lady. Establish a good rapport with the person and sometimes with the family too. Use very simple language and allow the women to clarify her doubts. And if she's made up her time and a mind for termination of pregnancy, assess her for the procedure before you go with the technology. And the relevance of counseling is you have to assure her and tell her also that there will be a quick return of fertility, and that's why a contraceptive method is very, very essential. And this is a very good opportunity to use to talk to her regarding the acceptance of contraceptive techniques. And always insist on having at least a 6 months gap between pregnancies, and that will give her more of health benefits and will always go on to a better future pregnancy outcome. And when you ensure contraception, remember you can reduce almost 90% of the abortion-related maternal mortality, which happens because of unwanted pregnancies. And when do you start your counseling? You start at the first visit and consultation when she comes for an abortion service. But if the exception is, suppose she has suffered a miscarriage, a spontaneous abortion, you can give a delay before you counsel her regarding the method as well as these contraceptive techniques. And what to counsel, the very important point is you have to tell her that there's a return of fertility in the next 10 days, and it can go on up to a month. So she has to go for a contraceptive method if she does not want the next pregnancy and again a problem with that. And you have to help her with the choices available. And it also has to be a method specific counseling, because every technique which you're going to offer will need to be told about the problems and the way to mitigate all those problems, and that has to be the part of your counseling. And high risk behavior, suppose she's having a history of sexually transmitted infections, or is a high risk category for repeated pregnancies and abortions, you have to take into account when you're doing your counseling. And please do not refuse an MTP method just because she's not willing for a contraceptive technique. And you can actually try to counsel her again after the procedure. And if she's still not willing, you can again call her for a follow-up. And repeated counseling may allow her to go for a contraceptive method instead of putting her under problem with every pregnancy. So how will you assess the suitability for the post-abortion contraception? The general principles are, you have to ensure that the abortion process is complete. You have to always see that there's no existing infection because of the procedure. There should be no injury to the genital organs, and you have to always rule out a fresh pregnancy before you offer a contraceptive method. And the critical role is the lady has to understand the precautions and care needed during the post-abortion period when you're offering the service. And the opportunity to counsel for contraception can be done in the post-abortion period, which is not accepted previously. And you need to reinforce the need for continuing the use of contraceptive method. And whatever method you have advised her, she has to be told that she needs to continue for a period of time so that she has the health benefits because of the contraceptive technique. And these are 3 points in post-procedure counseling, and that is, you have to ensure privacy and confidentiality even in the post-abortal period. Reassure her if she's got any problems. Repeat the information of the post-procedure care and the danger signs which she needs to be careful about. And suppose she's already opted for a counseling, you should appreciate her. And the immediate care and the immediate contraceptive service which can be given in the immediate post-abortal period is the IUCD and the medroxyprogesterone acetate, the depot preparation. The ongoing methods will be with oral pills. With an IUCD or with a injectable, she's quite free for the next 3 months or 5 years. But with oral pills, she has to be told that she has to continue it in the proper protocol. And you have to put up a follow-up protocol for any technique which you have asked her to continue. And the continuity, the reproductive intuition that the patient has to be re-emphasized. And you can offer cards so that she has got an easy access to information. Suppose she is undecided, you can allay her anxiety about the contraceptive methods available and the importance of immediate adoption of the contraceptive services, and the ones she chooses has to be emphasized. And the extended period of adoption of these contraceptive devices or techniques have to be emphasized. And as much as possible, if the lady is undecided, call the couple and counsel them as a family, and you may have a result with that. And you have to talk about emergency contraceptive pills if she's not accepting any family planning advice. What about the techniques which are available for contraception in the post-abortal period? The first is a barrier tech method. That's a condoms used by the male or the female that can be used as soon as sexual reactive activity is resumed, both in the first and the second trimester. You can tell her that there are no hormonal side effects and can be used without consulting a health provider. It's quite easily available. It will prevent against sexually transmitted infections, which includes HIV, and also enables a man to take responsibility of contraception. But you have to tell her about the failure rate of condoms which it's not used correctly. And regarding other method of intrauterine contraceptive device, they can be used after first trimester or a second trimester abortion. You've got the 10-year property, which is the IUCD 380A, or the 5-year one, which is IUCD 375. And the technique of using for the patient is she can get inserted immediately after first trimester abortion or second trimester abortion. It can go up to 12 days after the procedure, but that's only with the surgical method. Suppose you're done with the medical method, a property can be inserted only after day 15 of the process, because you need to ensure that all the products of conception are expelled, and you have to ensure that there's no infection, and you have to ensure that there's no other contraindication after the medical method. But with the surgical method, you can insert immediately or up to 2 days after confirmation of a completed abortion. And second trimester abortion, the technique is same. You can insert immediately up to 12 weeks. It's very effective. It provides long-term benefits of contraception that cannot put a property for a person who's undergone a medical method of abortion. And suppose it's a second trimester abortion, you need more qualification. A PPIUCD trained doctor will need to put IUCD if she's undergone a second trimester abortion. I have to tell the patient that there's no interference with sexual activity. There's an immediate return to fertility on removal of the IUCD, and there are no hormonal side effects. Regarding the combined oral contraceptive pills, it can be also given immediately after a surgical abortion. In a medical abortion, you can give it on day 3 of the dose of misoprostol, or within 15 days of the process of the completion of of the confirmation of a completed abortion. Suppose she's undergone a surgical method, you can put up to 7 days after the abortion, or from day 1 to day 7, the oral contraceptives can be started. In second trimester abortion also, you can start it immediately after the abortion process or up to 7 days. You have to tell her that the advantage is it can regularize her menstrual cycles. It can be provided by all health workers after first screening by the trained provider. There's no interference with sexual activity. It will offer protection against ectopic pregnancy, endometrial carcinoma, ovarian carcinoma, and benign breast diseases such as fibrocystic breast disease and fibroids. But it's not suitable for women who are breastfeeding babies less than 6 months of age. Regarding the long-term contraceptives, that is the medroxyprogesterone acetate depot injectables, it can also be given immediately after first trimester abortion done surgically, up to 7 days with a surgical technique. And with the medical method, it can be started on day 3 with the dose of the misoprostol. In second trimester abortion, it can be given immediately after the abortion or 7 days after the abortion. It's highly effective. Confidentiality and privacy will be maintained. It can be provided by doctors, MBBS and above, even Ayush doctors, ANMs, nurses, after screening by the doctors for the first injection. There's no interference with sexual activity. There's no effect on the quality and quantity of breast milk. There are no hormonal side effects in the form of estrogenic side effects. And there's no, it offers a protection against ectopic pregnancy, ovarian cancer, iron deficiency anemia, and uterine fibroids. Female sterilization is a permanent method of contraception. It can be offered after an abortion in the absence of any infection or severe blood loss, concurrently up to 7 days. Both mini lap and lap sterilization can be done after first trimester abortion. But if she's undergone a medical method, it can be done only after the first menstrual cycle. We have confirmed that all the products of conception has been expelled. In second trimester abortion, a mini lap sterilization can be done concurrently with the procedure, up to 7 days after an abortion in the absence of any infection or severe blood loss. But remember, laparoscopic sterilization is not recommended after a second trimester abortion. This is a permanent method of contraception, very effective immediately. There's no interference with sexual activity. There's no effect on breastfeeding. There are no long-term side effects, and it offers protection against ovarian cancer because you block the tubes. Vasectomy is a male method of permanent contraception done on males. It's independent of the timing and procedure of the abortion services. It is also very effective. It's a permanent method. There's no interference with sex. There's no long-term side effects. And the couple must use another method until the at least the semen count comes as nil. So this is the days you can start contraceptive services after you've offered abortion. With when she's going for a contraceptive pill, you can start from day 3 up to day 15. But after day 15, when you start, it's not going to be effective because the next egg would have come. Injectable contraceptives can be started from day 3, even up to 15 days. Sencromon can be started on day 3. IUCD can be given up to 15 days of the procedure. With the surgical method, at once it can be put, but with the medical method, you will need to confirm that the procedure is complete, that there's no infection or injury before you put the property. Tubal ligation can be done at any point of time. Suppose with vacuum aspiration or surgical technique, a contraceptive pill can be given at any time after the abortion process, up to 7 days. Injection, the same thing. You can start after the surgical method, up to 7 days. Sencromon also will have the same indications. IUCD can be put up to 12 days after a surgical method. After that, it may not be effective. Tubal ligation can be done at any point after a vacuum aspiration. So what about teleconsultation and other technology in sexual and reproductive health services? Leveraging technology for service provision can be in the form of teleconsultation, telecounseling, teleguidance, telereference, and telelinkage. And you've got lots of information on the website in the form of Hamdo, social media. Ask Tanu or YouTube will have information on contraceptive techniques and abortion services, infographics, helpline, and there are patient education platforms in WHO, the Ministry of Health and Family Welfare, and the Royal College for referencing. But when you go for teleconsultation, the SWOT analysis when you do, The strength of this technology is it was very useful in the COVID era. It was approachable throughout the process, so there was confidence because the patient could contact at any point of time. They need not travel for that. And there was more awareness because the questions were spread out and it was answered with ease by the provider. But the weakness of teleconsultation is there's no face-to-face talking with the patient. You cannot demonstrate a technique to a patient through teleconsultation as comfortably as you can do face-to-face. The opportunity is there for privacy and comfort in teleconsultation. It's definitely cost saving, and the number of visits can be cut down when you offer the technology through teleconsultation. But the threat is missed opportunity. The patient may not come for a counseling or may not come for a procedure after talking to you over the phone, over the teleconsultation technology. There's a chance of misdiagnosis because you're not seeing the patient. The checking of the patient, the investigations of the patient are needed, may not be done adequately, and that may go for a misdiagnosis. What is the applicability of the components of CAC, that is confirming diagnosis, assessment, and contraceptive need? And it can be used for that, where you can assess the patient and give the contraceptive. You can do a counseling through video conference or Zoom, and follow-up of the patient is quite easy with teleconsultation. You can offer a hybrid service where you can see the patient first time and then the counseling part can be given over teleconsultation. A single visit is enough. In MMA, you may need 3 visits for the patient to come to the center. So the key messages regarding the post-abortion or pre-abortion counseling services, the provider has to realize a need for counseling always. Always try to bring the couple on board and strive for 100% coverage. Capitalize on the basket services of contraception and the applicability in the post-abortal period. Use technology as far as possible, and there's a scope for entry in CAC services. And this concern with the policy, malpractice, service cost, and access is there with technology, but that can be mitigated if done correctly. Adolescent reproductive health will need both online and offline consultations for effective services. Thank you so much for a patient hearing. Shrima?
Yes, madam.
I think it's over, no?
Yes, madam. I'll share you the link, madam. Please inform them in the group to do the process and feedback.
Dr. Shalini has joined.
Ma'am, for the vote of thanks session, ma'am.
Okay.
Thank you for the session. So, Mr. Sriman, can we start with the vote of thanks session? Ma'am, can we start?
Yes, ma'am.
Yeah, you can. Yeah.
Yeah. Good afternoon, one and all. We, on behalf of Chittoor Obstetrics and Gynecological Society, would like to thank Foxy and its team and President Dr. Shantakumari ma'am for this one organizing this wonderful program, Respectful Abortion Care, the Foxy, WHO, and Government of India initiative. And I would like to thank our master trainers, Dr. Alka Mukherjee ma'am, Dr. Rekha ma'am, Dr. Sharmila ma'am, and Dr. Apurva Kumar A.K. Datta sir. It's wonderful to have all of you as our master trainers for this wonderful session. And I would like to thank all the delegates who have joined for this session. And Chittoor Obstetrics and Gynecological Society is a newly formed society. And this is the first official Foxy program we have. So we are immensely happy to have had this program. Thank you, everyone.
There's actually one question in the chat box. Can I answer that?
Yeah, please, ma'am. Thank you.
Regarding the medical board formation. You don't have a medical board in Chittoor? Dr. Shalini? Dr. Shalini? You don't have a medical board in your place?
Yeah, ma'am, we have a medical board, ma'am.
Because they've asked that question in the chat box. I think you have to tell them that there's a medical board there.
We have delegates from all over the area, ma'am. I mean, it's online CME.
Okay.
So it's a general question.
You can just inform them regarding the place where the medical board is there so that they can utilize the services for abortion service.
Okay, sure.
Thank you so much.
I've posted this link, madam, persistent feedback link. Please click on the link and submit your persistent feedback. Within 7 days, I will issue the certificates.